Okay, so thank you, Dr. Mahesh, for allowing me to present these 3 pearls in intravitreal injection. As you can understand, intravitreal injection, madam says 20 injections are now being given. So it has far surpassed the number of procedures. Any other procedures, probably non-contact tonometry and autorefractometry must be the procedures which are more frequently done than intravitreal injections. So there are lots of different types of intravitreal deliveries, etc. Anti-VEGF being the main thrust, but we do other for a lot of indications, including AMD. These are age-related macular degenerations or submacular hemorrhage, polypoidal choroidal vasculopathy, radiation maculopathy, retinal vein occlusions, diabetic macular edema. So all these are indications, proliferative diabetic retinopathy, advanced PDR, and even in endophthalmitis or antiviral sometimes and steroids. Sometimes we do inject gases, anti-cancer drugs, vitreolysis, and now coming on to newer things, stem cells and gene therapy will also be intravitreal. So this many procedures being done, and especially in a busy center, there's going to be about 10 to 20 injections every day. And Pearl 1 is identity. You have to identify the patient, you have to identify the eye, and you have to identify the injection. Because any mistake there is unpardonable. It is like operating the wrong foot or taking off the other kidney which is normal. It is completely unacceptable and unpardonable. So the surgeon will be scrubbed up. The surgeon will have some 10 or 15 injections to go, and then there may be some few surgeries to do. So the theater is busy, and there will be somebody bringing that patient onto the table, and the patient will be in cap, mask, sometimes all those things, and the patient will be lie down, and maybe the surgeon is so fast that probably he will only see a draped patient on the table. It is extremely important to look at identity. So both eyes may have a problem. So we should know which eye is the problem. So we have to earmark that particular person, probably the tag, and probably when the patient lies down, you should ask the patient's name. And sometimes the patients may also be apprehensive and they may not come out with a name also. So then you should have that idea that this is this particular patient and ask the patient, are you so and so? See, sometimes if you ask, so are you so and so, he may be apprehensive about the injection if he's a first timer or something like that. So generally have a tag of the patient's name, and the eye you should mark very, very clearly so that we don't mistake the eye. And get the file of the patient, or get the printout, or get a small sheet done in which patient is getting which injection. So these 3 things, identity is a very important. So these are some of the identity markers. Patient identity with tags. You can have a good mark, either this or maybe something which is white plaster which is put there or something like that. And drug identification with the case sheet. Probably you can just before the injection. During the injection, please do not talk much, because there may be, because even if we are wearing a mask, it may be better not to talk too much. But before the injection, please do ensure that the correct injection is going in. Pearl number 2, asepsis and pain management. Okay, intravitreal injection is something in which you are directly injecting whatever it is into the vitreous. And if it is an infection that you are bringing in, it is immediately going to be in fire. The endophthalmitis of a intravitreal injection is also very, very rapid, and it can actually be very devastating. You can lose the eye. Many patients with diabetic macular edema or AMD with good vision with 6/12 or 6/9 after an end-off will go to hand movements, something like that. So asepsis is a very, very important thing. Location usually is the OT, but a clean room without any contamination is acceptable. Set up all aseptic precautions. Whatever you do for cataract, you should have here. Preoperative preparation, informed consent, pupil should be dilated, and topical anesthetic agents do really well, because if the patient is in pain, he will not come back for the second injection or the third injection. So, maximally reduce the pain, use slit speculum, and very, very clearly put betadine 5% or 10% on the cornea, on the ocular flora, so that we have. And 3 minutes contact time is what betadine will do. So 3 minutes contact time is what we need to do, and then give the injection. Pearl number 3, drug dosage and IOP management. See, we have a 1 ml syringe in which we require 0.05 ml usually to go inside the eye. So in a 1 ml syringe, if you have 0.1, if you draw it to a 0.1, there are some space in the hub of the syringe as well as in the needle. There is some dead space. So make sure that you put your this dead space is filled with medicine, and then your piston goes up till about 0.05 ml, so that only that much volume can go in. And usually with that volume, the pressure does not rise. But if it is a glaucoma patient, or if it is a patient with a problem, a labile disc, basically get that. Okay, and this is a small video of injection. These are the 3 pearls that I would say. Number 1, identity. Identity of the patient, of the eye, of the medicine. Number 2, asepsis. Absolute aseptic precautions and pain management. Number 3 is correct dosage going inside the eye. So make sure that the needle does not touch anywhere, not even the lid margin. Directly go to the center of the eye and inject. And if in case of doubt, maybe you can take a bit of aqueous out by doing a paracentesis as well. Thank you very much.
Thank you, Gopal. This talk is very important because nowadays a lot of people are doing cataract and medical retina specialty, and the number of injections are increasing. We see more complications like endophthalmitis also in the last couple of years with the advent of biosimilars, which are being used by a lot of people. So